By sepsis 3 criteria, sepsis is a life-threatening, dysregulated host response. The condition triggers aggressive, systemic capillary dilation, forcing catastrophic fluid leakage into the surrounding tissue. The diagnostic trigger for this state is a sudden drop in organ function, quantified by a sequential organ failure assessment, or SOFA score, increase of 2 or more points. The terminal phase of this cascade is septic shock. At this stage, the patient exhibits persistent hypotension, requiring vasopressors to maintain a mean arterial pressure of 65, coupled with a serum lactate level climbing above 2 millimoles per liter. Identifying this state initiates the 1-hour bundle. This is a strict chronological sequence that dictates survival. Step 1 is immediate measurement of serum lactate. This maps the extent of the patient's tissue hypoperfusion. Step 2 requires drawing dual-site blood cultures. These cultures must be drawn before any antibiotics touch the patient's bloodstream. Administering antimicrobials first will rapidly sterilize the diagnostic sample. Violating this sequence blinds you to the precise pathogen. It turns the subsequent days of targeted therapy into clinical guesswork. Steps 3 and 4 occur simultaneously: the deployment of empiric IV antibiotics and the mechanical push of a 30 milliliter per kilogram crystalloid fluid bolus. This massive fluid push is a mandatory mechanical expansion for any patient presenting with hypotension or a lactate level of 4 or higher. Many patients will hit a hemodynamic fork, situations where that 30 milliliter per kilogram bolus fails to restore a MAP above 65. Here, you immediately escalate to norepinephrine as your first-line vasopressor. Norepinephrine rescues the patient not by adding more volume to the system, but through alpha-1 adrenergic agonism. It clamps the vascular container down to match the remaining fluid inside. Empiric antibiotic selection requires a calculated physiological trade-off based on the suspected source and local resistance patterns. You have to account for enzymatic evasion. Extended-spectrum beta-lactamases, or ESBLs, easily hydrolyze early-generation antibiotics. Confirmed or highly suspected ESBL infections mandate the use of carbapenems, such as meropenem. AMP-C beta-lactamases present a different threat. They possess inducible resistance that can emerge mid-treatment. Treating an AMP-C organism requires deploying a 4th-generation cephalosporin, specifically cefepime. You also must define the specific risk parameters that justify aggressive empiric pseudomonal coverage, typically severe neutropenia, recent IV antibiotic exposure, or cystic fibrosis. Covering multi-drug-resistant organisms requires matching the drug's structural generation to the specific enzymatic armor of the pathogen. For suspected MRSA, vancomycin is required to target the D-ala-D-ala terminus of bacterial cell wall synthesis. Pharmacokinetically, vancomycin operates on a notoriously narrow therapeutic index. This chart shows the drug concentration curve over time. The absolute target is an area under the curve to minimum inhibitory concentration ratio of 400 to 600. Dipping below 400 results in clinical failure, allowing MRSA to rapidly multiply. Exceeding the 600 threshold crosses into profound nephrotoxic risk, directly causing proximal tubule necrosis and acute kidney injury. Empiric coverage is a strict risk allocation. Overshooting the dose is just as dangerous as the infection itself. The diagnostic workflow frequently collides with the 1-hour bundle during acute neuroinfectious emergencies. The standard protocol for suspected bacterial meningitis is to confirm with a lumbar puncture, then treat. You are looking for a specific bacterial CSF profile: high polymorphonuclear leukocytes, low glucose, and high protein. The workflow changes when patients present with altered mental status, papilledema, focal neurodeficits, or severe immunosuppression. These patients must receive a head CT before the lumbar puncture to rule out mass effect and prevent uncal herniation. Junior clinicians often hold antibiotics while waiting for the CT scanner, aiming to preserve the integrity of the LP cultures. The diagnostic workflow must be decoupled from therapeutic intervention. You push the empiric IV antibiotics immediately. Antibiotics might slightly cloud a delayed CSF culture, but withholding them allows the bacteria to cause irreversible ischemic brain injury in a matter of hours. Consider a 55-year-old post-chemo patient with fever, profound neutropenia, nuchal rigidity, and a crashing MAP of 50. This presentation requires the immediate deployment of broad-spectrum bactericidal agents to neutralize circulating pathogens before they reach cellular receptors. The required sequence is: draw cultures instantly, then push dexamethasone, vancomycin, cefepime, and ampicillin. Cefepime is selected over ceftriaxone to cover Pseudomonas because of the neutropenia. Ampicillin is added to cover Listeria due to the immunocompromised state. Dexamethasone must be pushed before or exactly with the first antibiotic dose. The sudden antibiotic-induced lysis of bacteria inside the subarachnoid space triggers a massive inflammatory cytokine storm. The steroid is required to prevent that lethal reaction. Now escalate the scenario. The patient has received the 30 milliliters per kilogram fluid bolus, the antibiotics are in, and norepinephrine is running, but the MAP remains stuck at 50. When shock is completely refractory to catecholamines, you must look for hidden variables. The patient's history of chronic prednisone use for lupus points toward a specific hemodynamic failure. Chronic exogenous steroid use suppresses the adrenal glands. Under acute infectious stress, the body simply cannot mount the physiological cortisol demand required to maintain vascular tone. Immediate IV hydrocortisone becomes the terminal rescue step when alpha-1 agonists fail. Finally, if the patient has a central line, you must investigate a possible catheter-associated bloodstream infection, drawing cultures from both the central line and a peripheral site. Sepsis management is a kinetic algorithm where securing hemodynamics and hitting precise pharmacokinetic targets must occur simultaneously and without hesitation.